Our second speaker is Dr. Beverly Lorraine Ho. She is the Special Assistant to the DOH Secretary for Universal Health Coverage. She is the Chief of the Research Division of the Health Policy Development and Planning Bureau of the Department of Health. She was a former research associate of the National Telehealth Center. When she graduated from the UP College of Medicine, she received an Outstanding Leadership Award. She has a Master's in Public Health from the Harvard School of Public Health. Friends, let us welcome our two speakers, Dr. Iris Tan and Dr. Beverly Ho. Dr. Beverly Ho, you may want to start your lecture, please. Thank you.
Good morning po. I'll just share my slides po. Good morning. Good morning, everyone.
Good morning.
Hi. So, good morning. Today, I've been tasked to make the presentation on the new normal. No? Most of what is here are based on government issuance, specifically on the DOH issuance on minimum public health standards, as well as the issuances of DOLE and DTI for all the industries. So COVID-19 has disrupted operations in the entire country, both in, say, tourism, revenues of many industries, also declining household consumption, largely because of limited economic activity. And then lastly, sectors that are not part of food and health-related supply chains are likely to bear also more significant losses. It has tested the surge capacity of our healthcare system. As of yesterday, we have 11,000 cases. But at the same time, it also challenged us in the health sector to ask ourselves why there are many more healthcare workers who are affected by COVID compared to other countries. No? And you will see at the right-hand side of the screen, most of those affected are nurses and physicians more than the other cadre. So then we ask ourselves, how do we actually transition into what people have been calling as the new normal, or the state which we need to sort of practice before any vaccine anti-COVID will actually be implemented. So we're told that the new normal will require a new mindset. We will need to let go of our familiar lifestyles. We will need to have increased awareness of what we do and our surroundings. And also to incorporate extra precautions in our daily routines. I've said it in a couple of conversations with mentors and colleagues that the new normal actually presents a lot of promises for universal healthcare in the country, contrary to what we initially thought, that COVID will stop most of the UHC reforms in the country. What we've seen is actually it could accelerate what we want. No? So for example, the UHC law talks about having a new generation of Filipinos who are more health literate and conscious. I think that's slowly happening. Next is it also talks about us having an environment that supports this health literacy mindset. No? So it means that we have a built environment that is conducive for practicing healthy or safe or infection-free lifestyle. So that's sort of happening, and maybe later that's why Ma'am Iris is here. It's also triggering us to have to actually finally go into more IT-enabled healthcare services. So According to a medical anthropologist from the Johns Hopkins Center for Health Security, people will change their behavior if there are three conditions that are in place. They know what to do, why they need to do it, and see other people like themselves also doing it. So the third is like mostly like modeling, no? So if we have these three things in place, changes in behavior, which are usually difficult to have, will happen. So this just shows a framework of how we'd want to reduce not just COVID-19 related deaths, but also non-COVID related deaths. And actually the first four parts are what we actually are prescribing or are encouraging a lot of the people, the enterprises, the businesses to do or to use as principles in transitioning into the new normal. So this framework, I'm pretty sure everyone is familiar. The last three items in the reverse pyramid are usually what we try to adopt as framework in thinking through what can be done to support someone practice better all the new practices that we're expecting everyone to do in the new normal. So the engineering controls and administrative controls could be done by establishments, by businesses, by the institutions, hospitals, hospital administrators, apart from just providing PPEs, no? And the engineering and administrative controls, they say, are more effective than just using PPEs alone. So, as mentioned a while ago, what you will see in the next few slides are based on DOHAO, 2020-0015, and recently guidelines on workplace prevention and control of COVID-19 by DTI and DOLE. So first would be to increase resilience and how to cope with stressful times. And for our individual selves as healthcare professionals, most of you, it is normal. We have to acknowledge that it is normal to feel sad, stressed, or overwhelmed. No? But we have to maintain a healthy lifestyle, proper diet, sleep, exercise, and adequate social contact with friends and family, even if we are super busy with work. No? A part of healthy lifestyle is also avoiding binge drinking of alcohol and smoking and talking to people we trust or a counselor. And so, because of this, we also propose or encourage that companies or hospitals have a mental health program in place to support their staff. Now, at the same time, we are working with Philippine Sports Commission as well as DILG, DOTR, Transportation, and Department of Public Works and Highways on these two guidelines. No? Guidelines on the conduct of health-enhancing physical activities during COVID-19 pandemic and guidelines on active transport. So you will ask, ano ba to, no? So the one here on the left with Philippine Sports Commission says that basically when we are in high-risk areas, like where we are now in NCR, we can only do solo sports, no, in our private space and indoors, no, or maybe we can go out a bit and but just come inside after. But when we shift to GCQ, you're allowed to go into a public or private space and perform the exercises indoors or outdoors. But in all cases, non-contact sports and activities only. No? So, for example, you're training on judo. So those are things that are impossible to do whether indoor or outdoor because they are contact sports. And then the other guideline on active transport, the one here on the right side, you will see that what we are trying to propose is actually a more friendly pathway, no? Wherein people can bike to work, for example, if you're between 2 to 5 kilometers away from your workplace. So why is this so? Because we understand that the mass transportation mechanisms won't be in place, no, at least those in the ECQ areas, but for even in GCQ, they will not be maximally utilized. So there are estimates that it's actually less than 20 to 30% of the actual capacity, right? And so we cannot expect people to walk to work, no? So we have to promote safe cycling, for example. Um, Another one on increasing resilience would be to reduce exposure of vulnerable individuals. Um, so, for example, here on the right, you will see how the DTI and DOLE has prescribed this. So employers are highly encouraged to allow these workers to do work from home arrangements, and work from home arrangements should be developed to detail the deliverables from these employees, and there shall be no diminution in wages or benefit. So as much as possible, they should be allowed to work from home. So I think I missed this slide. So for increasing resilience as well, allowing people or encouraging people to cough on their elbows, etc. I already talked about mental health a while ago. In terms of stopping the transmission, just reiterating the 5 moments for hand hygiene, which everyone here is supposed to be familiar. Um, but I then put two bullet points down there, no? So we're talking about possibly changes in hand washing facility design. Not all facilities have those no touch hand washing facilities. And also, evidence is increasing about nudges to improve hand washing. So these could be like stickers. These could be stickers placed on, say, the mirror or the hand washing station. So a lot of these other nudges we will try um, to scale up in the different health facilities. No, we will be providing the hospital administrators with samples of these nudges. Another one in terms of stopping transmission would be appropriate use of PPE, no, or rational use of PPEs. Then would be environmental hygiene or disinfection of frequently touched surfaces. So in terms of reducing contact, practicing physical distancing by encouraging the use of stairs, changing the workstation layout to allow unidirectional movement, then roving officers present to ensure observance of protocols. Next would be to modify work structures and schedule, specifically providing alternative ways to report for work, or and this is especially true for people who don't necessarily have to be there physically present. And then the last one is restriction on mass gatherings. So shifting meetings, conferences, and other large gatherings to online platforms. So limit use or close pantries. And at least for us in the medical field, we may need to rethink our medical rounds, because typically when we go on rounds with our attending, we are like mass gathering, no, of like 10 people, sometimes even 20 people if there are students. Just echoing the other guidelines from DTI and DOLE, so face masks, and this is applicable for our health workers who are non-healthcare professionals, no? So maybe the cashier in our hospitals, or the people who process PhilHealth payments there. Kasi yung parang office-based people natin in the hospitals or in the clinics. So accomplish the health symptoms questionnaire and submit it to the guard or safety officer, having their temperatures checked, using alcohol and sanitizer, making the isolation area within specific workplaces well ventilated and disinfected. And if there is a long queue, roving officer shall be the one to enforce the physical distancing measures, no? And then also inside the workplace, yun, frequent disinfection, making sure that all washrooms and toilets have sufficient clean water and soap. Um, Change the layout, as we've already mentioned, and no eating in communal spaces. But if eating in communal spaces is impossible, or in individual work area is impossible, they shall ensure physical distancing still in the canteen area. Workers are discouraged from engaging in conversation with masks off. And this comes at the heels of several articles coming out today saying, what, 14 minutes? of virus exposure while talking to other people. Tables and chairs shall be cleaned or disinfected before and after use, as well as at the end of the workday. And canteens and kitchens should be disinfected regularly. So we also talk about shortening the duration of infection, meaning keeping people who are symptomatic very early on isolated. So on point number 2, you will see that we have to make it easy for our staff with flu-like symptoms to not report to work. No, meaning the penalties that typically come with missing work um, has to be made a little bit more rational during these times. And then maybe it's important to also balance that while the employers, so this is like hospital administrators and owners, for example, have tasks, we as employees or the healthcare frontliners also need to comply with certain measures. No, so it's a two-way street. Um, as regards to telemedicine and teleconsultation, I don't have any more slides on this, but I would just like to update everyone that we're very happy that the DOH has been able to issue out guidelines on telemedicine and in fact partnered with a lot of telemedicine providers in the past months because all of these were accelerated by the COVID situation. And we're hoping that as part of this initiative, or what we call sandbox regulation initiative, meaning no stringent rules were put in place except to ensure data privacy. We're actually using this model to shape how future primary care package of PhilHealth will be able to incorporate telemedicine and teleconsultation. No? So we're very open to seeing how this will be scaled up from the start.
Dr. Ho, are you done with your slides? Dr. Ho. Uh, anyway, thank you very much, Dr. Ho, for your very informative lecture. Uh, if you just joined us right now, don't worry, you will be able to watch the recording of this webinar via YouTube by typing in the search term, the Philippine College of Physicians. Um, Dr. Ho, if you're done, we will then proceed with the lecture of Dr. Iris Isip Tan. Dr. Tan?
Good morning. Continue. Okay, I'm going to share my slides. So good morning, everyone. As you know, I am on Twitter. And last Monday, I actually tweeted, I just decided that I hate hearing the new normal. And suddenly, I was asked to give this webinar today. And we all know what the title of today's webinar is. It's the new normal made ridiculously simple. Okay. So I've decided to talk about the telemedicine being the new normal. I will talk about the UP Medical Informatics Unit guidance documents and also a bit about my journey while being stuck here at home, not able to have clinic. My last clinic day at the PGH Faculty Medical Arts Building was actually March 13. So as you know, I do maintain a Facebook page, the Endocrine Witch or Doc Brew. So this was a post that I had March 14. So the first day I was stuck at home and I was trying to talk about how coronavirus is actually shredded into pieces by soap and how we should all do hand washing. When we talk about telemedicine, we talk about giving care or providing care at a distance. But if we look at the umbrella term telehealth, we're also saying we're providing health education, we're doing research, and that's part of the umbrella of telehealth. So that's what I was doing then at that time. And then on March 20, I read what Dr. Ronnie Baticolon had written in a CNN article. And already I was worried about the patients that I wasn't seeing at my closed clinic. And he said, and what about the indirect deaths? Who keeps a tally of Filipinos who will die from the lack of available blood for transfusion, skipped dialysis sessions, delayed surgeries for cancer, rescheduled radiotherapy sessions, missed antiretroviral medications, uncontrolled hemorrhage from childbirth at home, or even from hunger? So I was really thinking about that already. Several days later, I talked to the Diabetes Council of the Philippine Society of Endocrinology, Diabetes and Metabolism, because I was already seeing queries on my DocBrew page, and I had some frantic patients texting me as well. Their sugars were either going too high or too low, and they were on insulin, and they were unable to see their doctors to ask what they will do with their doses. And so we organized into teams. We had the group to do the content. We had the group to do translation. So we have these, what you see on my slide, both in English and Filipino, and we shared them everywhere that we could on Facebook and on Twitter. And we had someone to do the graphics. So it was a volunteer effort of so many endocrinologists to be able to put this together. And we've continued this. You might be able to visit the PSEDM Facebook page. We talked about things like, can you eat canned goods if you have diabetes, because that is what is being handed out. How do you make them more healthy? I recently saw that they talked about sunlight. Are we getting enough sunlight because we're inside the house, and how does that affect bone health? So these are the things that can be counted as part of telehealth, this education process. And earlier, Dr. Beverly Ho was talking about uplifting health literacy of our Filipinos. And then I started to worry even more because the Philippine General Hospital is a COVID referral center and the outpatient department was closed. Where were our patients? Kumusta na kaya sila? What are they doing? So we decided, I helped our fellows to craft a teletriage protocol. And this was simple SMS because we thought that perhaps because of the Wi-Fi connection issues, not having the devices, maybe SMS would be the best way to go. So some of our fellows already had the cell numbers of their patients, but not everyone. So we needed to provide a way for the patients to get in touch with the fellows in the diabetes, thyroid, and general endocrine clinics. At this time, the PGH also had the Bayanihan Center, and so people could also call there and get directed to our fellows in the specialty clinics. But this is my first experience on trying to come up with a teletriage protocol. So at this point in time, we were only willing to see old patients. So we had to find a way to verify that they are old patients of our clinics. We had to tell them, okay, this is what you're going to text, your case number, your age, etc., what clinic. And then we had to say, what are the services that we can provide? If there's no video or we are unable to see acute cases, what can we provide? So at the time you were saying, well, prescription refill, we could interpret some of the lab tests if you have them. If you have blood sugar monitoring, BP monitoring, perhaps we can titrate your medications and issue an e-prescription. So, and then in the following days, April 8th, I saw this tweet by Dr. Charlie Ray. And what you see there in the infographic is actually by Dr. Victor Cheng, and it talks about the human-centered waves in the pandemic. So the first wave would be the immediate mortality and morbidity of COVID-19. The second wave would be the impact of resource restriction on urgent non-COVID conditions. The third wave would be impact of interrupted care on chronic conditions, and that was what I was scared of. Fourth wave, mental illness, economic injury, and burnout. So if you see the tweet, Dr. Ray is saying, if the healthcare system lacks out and doesn't see the third wave of patients due to telehealth, digital outreach by primary care, how would this impact how healthcare moves forward after COVID-19? To me, this might signal and argue for a paradigm shift in how we provide care. So that third wave of the pandemic is probably here. And I see that a lot of doctors are trying to get online and do telemedicine because really we're seeing the impact of interrupted care on chronic conditions. So this was the day I saw the tweet. It was April 8th, and I was already seeing some problems. So I had a patient who got admitted because he was rationing his insulin syringes and was only giving one instead of two shots, etc. And he got admitted for a diabetic emergency. On my page, people were asking, this medicine is not available. Could I change to a generic one or another one? If I have two medications, can I just have one because I no longer have money to buy what's in the prescription? So these are the things that I'm still seeing. And most memorably, last April 24, I had a frantic text message from a patient who said that there's no more insulin on Catanduanes. And apparently there's only one mercury drug and one Watson's in Catanduanes, and both of them didn't have any insulin. I'm happy to report that this ended happily because friends reached out on Twitter. I was able to find a doctor to the barrio in Catanduanes, and he was able to find insulin for my patient. But these are the things that happened because of the quarantine. So there was a supply chain problem. As you know, insulin needs to be transported in ice or in cold conditions. And apparently because there was change in the flights or there are no flights, and then they have to shift another mode of transport, etc. So these are the things that we're working to solve. And so against that backdrop is how my students, my graduate students in health informatics, the faculty of the medical informatics unit thought we need to get together and provide some guidance on telemedicine. And this is our very first Zoom meeting after the Holy Week, okay? So far, we've come up with 3 guidance documents. So we call them chapters. So the first chapter is Telemedicine Guidance for Filipino Physicians. The second is Teleconsultation Guidance for Filipino Clinicians. And the third is Preparing for Teleconsultation Guidance for Filipino Physicians and their patients. Hopefully, we're able to release the 4th document today. The 4th document today is about assessing telemedicine platforms or vendors, how to choose one. And I know that many people are asking me that question, okay? Our guidance documents are available at that link. That's a Google Drive that contains the PDFs of all 3, bit.ly/UPMIU Telemed 2020. So in that first chapter, we talked about 3 questions. Who can practice telemedicine? What are the minimum competencies to practice telemedicine? And what are the minimum requirements to set up for telemedicine? I can't discuss in detail, so what I've done is looked at the calls to action because of the guidance document. So for example, one call to action is legislation to support telemedicine. And earlier in the chat box, somebody was already asking about legal safeguards. So as you know, the Medical Act of 1959 defines the practice of medicine as physically examining the person to diagnose, treat, operate, prescribe any remedy. So how do we do that with telemedicine? Because we cannot touch the patient. Thankfully, the DOH, or the National Privacy Commission, issued this joint memorandum circular on the guideline on the use of telemedicine in the COVID-19 response. I think this is what Dr. Bevho was alluding to earlier. And in that particular document, it says licensed physicians may engage in telemedicine despite the absence of physical contact. But the gold standard for clinical care remains to be face-to-face consultation. However, this is part of the COVID-19 response. So I was thinking that perhaps we need really legislation beyond the pandemic if indeed telemedicine is going to be part of the new normal. So the second call to action from our document is the incorporation of telemedicine competencies in health professions education. Do we teach telemedicine skills in our medical schools? Is it part of our training programs for residency and fellowship? So I'm getting asked a lot, what do we need to set up for our trainees? So in our document, we said, what are the minimum competencies? Well, digital communication skills, clinical acumen, knowledge of technology and equipment to be used, while adhering to ethical practice. So what is our website manner? So right now I'm talking to you in this webinar, I'm looking at my camera, I don't actually see the people. So it takes some doing to be able to do that and still sort of come across as your natural self. And then knowledge of technology. What happens if suddenly you are cut off while talking to a patient? Do you know how to troubleshoot? What if there's no audio? And adhering to ethical practice, so many issues have been raised recently, and I don't know the answers. So, for example, they asked me, should we charge the same, lesser, or more for a teleconsult? So this has been part of my new normal. So I've been trying to do video consultations, and here what I can say is I'm not late anymore for clinic because I don't have to travel. I'm just here at home. But I'm still figuring out my video setup. So as you can see, I have a virtual background because that solves a lot of my problems with my clutter. But also there's like glare in my eyeglasses, which I need to fix. So these are the things that I'm grappling with, and we need to be able to learn this. The second call to action is to lobby for faster Wi-Fi for everybody. So right now I'm on this webinar and I told everyone in the house, get off the internet so I can have all the Mbps to myself. But our patients, their Wi-Fi connections are also limited, and Dr. Bevho is here. We were discussing with some people, should the RHUs be equipped with a telemed corner? Can that RHU be given good Wi-Fi connection so that maybe patients can go there and be able to be seen for a teleconsultation? So what are the minimum requirements to set up for telemedicine? Well, you need your communication device, be it a phone with or without camera, and a computer. If you're using video or chat software, a stable internet connection, and a private, well-lit location is preferred. So in our guidance document, we said 2 Mbps per user if you want at least HD 720p resolution at 30 frames per second. For the dermatologist, if the patient needs to take a picture, it has to be about 5 to 8 megapixel with good lighting. So when we said 2 Mbps, that's per user. So in our second chapter, we talked about the teleconsultation itself, the guidance for those having clinics. And we had 3 parts. We classified the telemedicine consultations. We talked a bit about the virtual physical examination, and then the process flow. So it's something that even I myself have been refining over the weeks that I've been doing telemedicine. So what needs to be done before the consult, during the consult, and what happens after the teleconsultation. And here we have an infographic which is based on a paper that looked at what is possible with a virtual physical examination. As you know, when we do PE, we have inspection, palpation, percussion, auscultation. So not all of that, we can't do that, all of that, if we're going to have just a video consultation. And last week, I'd like to share with you some tweets from the first ever Cardio Bites Twitter chat with Dr. Donnie Magno. So we were with some of his cardio fellows. And the first question there was, how do we do a virtual cardiac PE? So someone said, go for inspection, do chest examination by inspecting the chest using the webcam. And so as I was saying, what? So you will ask the patient to disrobe the webcam? And I was thinking, how close do I have to be in the webcam for the doctor to see my chest, etc.? Should that be part of the consent? What about the privacy? What if it's being recorded, etc.? So these are the things that I don't have the answer. So that's why our call to action includes, please, the specialty societies, Philippine College of Physicians, the subspecialty organizations. We also need guidance for the virtual PE. When we came out with the diagram, for example, people were talking about the clinical eye, okay? But some of my pulmonologist friends also said, there is the clinical ear. So when a patient coughs on cam, I was told that they can tell, is it bronchitis, is it COPD, etc. So this might be skills that we need now to hone even more because of telemedicine. So the third document that we have there is preparing for teleconsultation, which is a guide for our patients. How can we as doctors help our patients prepare for teleconsultation? It's not just us, grappling with the technology and this new way of doing consultations. It's also the patients. And so we try to provide a guide for them. So how do we safeguard the teleconsultation? We need to protect both the physician and the patient. How do we document the teleconsultation? Do we elicit patient feedback? How do we do that? So we have some templates for patient feedback and for documentation inside chapter 3, if you want to check that out. In chapter 2, I forgot to say that we also have a consent form template in there, both in Filipino and in English. And I'd like to publicly thank Professor Vlad Gonzalez of UP for doing our Filipino translation. So here is one example that we had in chapter 3 to safeguard both the physician and the patient in a teleconsultation. We need to figure out which patient can be seen via teleconsultation. So this one comes from the National Health Service of London. It's about diabetes. I'm an endocrinologist. So it says virtual, telephone, video, or email. And then they have a list of cases. So it says follow-up of new diagnosis of type 1 diabetes. So follow-up, because if it's new diagnosis of type 1 diabetes, they put that under urgent face-to-face. Okay. If the patient's diabetes is stable and well managed, it says there defer appointment. Okay. So I think what we need to do first per specialty is to develop this kind of triage algorithms so as to guide everyone. And it will be different, I guess, for different specialties, how this is going to go. So this is our sample documentation template because we're saying that additional data will be needed. So again, someone was asking about the legal aspects, etc., of doing a telemed consultation. So in here, in our document, you were saying, we have to say, this is a telemedicine visit using, so what are you using? Viber, Messenger, or whatever telemed platform. And the patient has provided consent. Okay, and what was the date? We put their time and duration because we don't know if at some point PhilHealth will start reimbursing teleconsultations. Will it be based on the time spent, the type of case, etc.? We don't know. I am seeing the patient from, here's my location in Quezon City, and they are at wherever. What's important, we wanted to put there, what were the limitations of today's visit? So for example, you will say, patient complained of a wound on foot, on camera, this is what I saw, but I am unable to palpate, etc. So then you have to see what were the limitations. Okay, if there were any other attendees present, because I think I was being asked this last week for pediatrics, so there will be a caregiver or even for our elderly patients, and the decisions that have been made. So this is a document that we put together, but we encourage other people to actually look at it and add to it or refine it, revise it. And then because this was a patient-centered document, we wanted to encourage feedback and monitor outcomes. So we also have a patient satisfaction feedback document there. So was the patient happy with the teleconsultation? Was the audio video good? How was the scheduling? Would they recommend it? Would they do it again, etc.? We need to know. There was actually a systematic overview that looked at whether the patients felt that teleconsultation was somewhat inferior to a face-to-face consultation. What were the factors? So these are the things we need to find out for our own local situation. So the call to action is we need research on outcomes. So because we're going to do this, how do we know we're successful? When we do the teleconsult, do we lessen the hospital admission rate? Are we taking better care of our patients without exposing them to the dangers of the pandemic because we're not making them go to the clinic, etc.? So we need to find those outcomes. So this is actually my last slide because we have here the convergence of medicine and technology. And it's a quote from Protasio de Luz, who wrote about the MD-patient relationship in the context of telemedicine. And he said, we should use the best of the two worlds. preserving humanism in medicine, and using new technologies to improve medical care. And that is the challenge that is before us today. So again, I just like to show on the screen our link for the Google folder. And please let me know if you have comments or you would like to work with the medical informatics unit for the specialty specific guidance documents. Thank you very much.
Thank you very much, Dr. Iris Tan, for your interesting and wonderful lecture, as always. Thank you. I have to thank you. I was inspired by your lecture in 2005. That's why I took medical informatics as well. Uh, for those who just joined us, you can still access the recording of this webinar via YouTube on the Philippine College of Physicians channel. We'd like to give the first question by Dr. Antonio Kiambao to Dr. Iris Tan. And the question is, are there legal protections for doctors regarding telemedicine and teleconsultation?
So I tried to answer that during my presentation because I saw the question earlier in the chat box. So we do have that DOH, National Privacy Commission, joint memorandum order that says we can do telemedicine without physically examining the patient. They had to say that because the Medical Act of 1959 says physically examine. So far, that's the only thing I can quote, not unless Dr. Bevho has some other issuances that I'm not aware of. But that's why I was saying we need actual legislation. Senator Sani Angara filed a bill on digital transformation. And we're looking at that, if that can be also a jump board for, defining the practice of telemedicine, because it talks about IT literacy, etc. So maybe you should also check out that bill, that Senate bill that was filed, I think, last May 6th.
Thank you, Dr. Tan. Dr. Ho, did you want to add something to the answer of Dr. Tan? Kindly unmute yourself, Dr. Ho.
Yes po. So, no, I'm okay na po, Doc Iris's answer. Everything is still like evolving as well for us. And so any new data, new findings that will come out that will support a more like aggressive or progressive policy, we would really appreciate everyone's support po.
So there are two questions for you, Dr. Ho. One is on the requirement of employers for their employees to take a rapid screening test before returning to work. Is this supported by the IATF and DOH, and who will pay for it?
Based on IATF resolutions, any guidelines as regards to testing will follow DOH guidelines. So in the DOH guidelines, we mentioned that rapid tests are only to be used if in the context of research, and also when they have already been validated. No, so that just means that we cannot require the use of these, especially if they haven't been validated. So what has been ongoing now is that employers are doing this on a voluntary basis, no? But it is very clear in our policies that this can only be done in coordination or as a supplement to RT-PCR testing. So in that view, we cannot and we will not require employers to use rapid testing. And because also of health technology assessment, which says that the DOH and PhilHealth cannot reimburse cost-effective interventions, and they have ruled that rapid test kits are included in that, that means we cannot pay for it. No, so DOH will also not fund it, as well as PhilHealth.
Okay. So Dr. Ho, maybe the Department of Labor and Employment should also be part of the process to inform the employers that this is an incorrect way of doing things. Okay, thank you. There's a second question for Dr. Ho. This is with regards the criteria for reopening clinics or the outpatient department in tertiary hospitals? What would be the safe criteria to do so?
Sir, ever since the restrictions were put in place, it was clear po that the frontline healthcare providers are, hello?
Yes. Yes, we
Hello,
can hear
ma'am?
you. Yes, Dr. Ho, we can hear you. Dr. Ho, yes.
Okay po. So the frontline healthcare providers are not required to not open their clinics, no, or are restricted to open their clinics. So it will really depend on how prepared or how mentally physically ready their environment also is. So kung yung clinics po are in the hospitals, as long as the hospitals can institute certain measures, yung engineering and administrative controls, for example, to make sure that patients don't mix, diba, with people who go to the ER, for example, all those safeguards are in place, then there will be no issue from the side of DOH naman po to prohibit the clinics from opening or closing.
Okay, thank you so much. Dr. Iris Tan, there is a question here on the informed consent. And before I actually ask this question, I would like to ask the question, uh, if the vendor or the hospital technical team insists that the terms of privacy and terms of use are actually equivalent to the informed consent, how does the doctor then go about uh, requiring or obtaining an informed consent from his or her patient? Thank you.
Millie, you know, you and I have been discussing this because you were also part of our MIU guidance document. I'd like to inform everyone that Dr. Millie is also an MS Health Informatics graduate. Um, the thing there is the terms of use usually have to do with the software. In our informed consent for telemedicine, we talk about other things that are more clinical. So, for example, we tell the patient what are the limitations of this um, teleconsultation, what are the risks, which is beyond what just using the software is. And that's why we're inviting people to actually look at the consent form and modify. So Dr. Millie helped us putting that together. So I think you will have to find other means to do that. In my personal practice, what I've done is I've required patients to email me the signed consent form before we start the teleconsultation. And then we were told by Dr. Marcelo that according to the lawyers, it's not only that we make the patient sign the consent form, we have to explain it to them as well and ask them if they have any questions, which we can do either before the visit or at the very start of the visit. So we need to find, my opinion is, I'm not a lawyer, but I think we really need to have them sign a consent separate from the terms of use from the telemedicine vendor. I was talking to one vendor recently and he said, oh, we read your guidance and we're thinking already of how we're going to put it on the platform. So I guess maybe if you're using a particular platform, tell them, could you please incorporate the consent form. Now, if a hospital is going to use it, we have already said in our guidance, please have it cleared by your legal, have it cleared by your data protection officer, because of course, they are more knowledgeable on how this consent form should be worded, etc.
Okay, thank you very much, Dr. Tan. So there's another question on the legal issue if the employer still insists to have their employees tested at this point. Dr. Ho, can you maybe talk about that?
Ma'am, based on the guidelines po, before the test could be administered, parang the safeguard that we put in place is that it has to be a medical doctor who has to oversee that entire process. No, not necessarily draw the test or the parang do the entire procedure, no? So, it could be some phlebotomist kung kailangan ng blood draw or some nurse or med tech who can do it. And then basta the indications will have to be certified by the medical doctor. So we're hoping also that the medical community will be circumspect in ensuring that parang whoever is only indicated to undertake such test, and also which specific testing kits um, will actually be used will be up to the medical practitioner, no, na parang we encourage naman, I think we expect that the medical practitioners will be very responsible about this, no. So since sila yung and all the companies who are doing it are required to submit the data along with who the medical doctor who's helped them administer it, we're hoping that may sense of responsibility from their end po to do it.
Okay, thank you, Dr. Ho. Dr. Dante Morales is asking whether these webinars are shareable with everybody. Well, actually, the webinars are uploaded in YouTube in the Philippine College of Physicians channel, so it is going to be viewable by everybody. There is a question for Dr. Iris Tan. Will telemedicine worsen health inequities given the discrepancy in technological and informational access across the different socio-economic strata?
So that's really something we need to watch out for. And that's why I was listening to Dr. Bev Ho, and she was already talking about, infrastructure changes on how we do things. I think the same has to happen. So that's why I included a call to action, for example, to get stronger Wi-Fi. How are we going to do that? If you can't have every patient have strong Wi-Fi, can the local government units have one place in an RHU or in a health center to have that place where patients can go to get good Wi-Fi access, etc. Now, I'm trying to work on some telemedicine guidance for diabetes because I'm an endocrinologist, and we're looking at how can we use messaging apps because that's lower bandwidth. So we're trying to develop templates like, okay, if it's just reporting the blood sugar, because the other day I had someone in the consult and she was holding her blood sugar diary on paper and she was holding it close to the camera so that I could see it. But that could actually be sent via some secure messaging app. So we're trying to look at low bandwidth approaches to telemedicine. It doesn't have to be entirely video. But we need to work on those so that we can really say that we're not worsening the inequities.
Thank you, Dr. Tan. There is a question on physical examination requirement in the industrial clinic. This is likewise a mandated thing from DOLE. So do we have a guideline in this? I think they're trying to say they used to do physical examination face-to-face. And now, how do you provide a physical examination in telemedicine for the annual physical examination?
Maybe Dr. Bev can answer because there are some questions that you actually need to change the regulations. Maybe I don't really know because as I have discussed in my presentation, there are really limitations to doing it virtually. One thing we're looking at is having telepresenters. This might be like a nurse or a barangay health worker or a midwife together with the patient, and that telepresenter will be the hands and ears of the doctor who is at a distance. So for example, I can visually inspect, but then I can tell the nurse, can you palpate? Is it soft, doughy, hard? At least she knows those terms. But really, if it's about regulation, maybe Dr. Bev can talk more about this.
Dr.
Hi, ma'am. So, ma'am, we do have a research commission in place po to update the PHEX guidelines from long ago, and we're expecting that this should trigger our discussions with DOLE. But this was done. Requested early on kasi PhilHealth was also gonna expand the primary care package, di ba? And people have been saying, oh, it's not enough kasi parang yung concept nila of a primary care package is everyone has to do all these tests, di ba? Kasi yun yung typical for an annual physical exam. So yun po yung context why we also wanted to update the guidelines. But at the same time, things were overrun by COVID. And maybe, again, this is a silver lining to updating this very outdated practice in the Philippines, no, of mandating these annual PE na may not also be cost effective. Thank you, ma'am.
Okay, thank you. Certainly, this pandemic caught everyone by surprise, and we really have to move into making new procedures for the new normal. Uh, so there's a question here. Uh, I don't know if this can be answered, but this was addressed to Dr. Ho. Can PhilHealth increase coverage of COVID suspect and COVID probable admitted in the hospital? Because PCR results come more than a week. Dr. Ho?
They based their calculations also kasi from the first round, no? So before April 14, so they looked at the records of the patients admitted in the hospital. So that was the basis, no? Siguro, yeah, probably they could update it. We could just tell them maybe to collect new rounds of data po if it's needed.
There's another question. Will there be any recommendations to be included in creating health declaration forms?
I'm not sure what the question is, ma'am.
Okay. I okay. Maybe Dr. Mantaring can help us clarify this question, and we'll get back to that question once it's clarified. There's another question from Dr. Ana Diente, and her question is that my medical malpractice insurance recently informed me that it will not cover pandemics, COVID, or infectious disease related claims. Can you comment on this?
I'll need to get more information about it. This was the first time we got asked about this, and maybe we'll need to check po. Thank you.
Okay, thank you. So, okay, so there's a question. What about employees that are fit to work, but they are being required to have testing, COVID-19 RT-PCR testing?
Actually, ma'am, in all our guidelines, they couldn't be required because there's a prioritization mechanism that we have, no? So severe, and then mild, vulnerable, and then mild. And then actually yung lowest doon are asymptomatic contacts, di ba? And even up until this point, even if we've reached 9,000 tests per day, we cannot possibly keep testing everyone because every single day they might also be actually infected, di ba? So anong point of testing? We have highlighted this a couple of times already with our partner agencies, and to some extent, kaya din parang they've been I guess the employers themselves have been doing the rapid test because they know that it is really impossible to do the RT-PCR testing for everyone. With that said, parang efforts are being made to really fast track the validation of the rapid test kits because apparently people just sort of really need that parang security blanket, no? So ano naman yung pwede nating gawin, no? So sa side namin, we're trying to get it out din yung the need for better information to the public why this is not needed. At the same time, we're hoping that the medical community, hence this partnership with PCP, will also be able to echo that because you are doctors of influential people as well. You get invited and requested to advise influential people as well to make them understand this. And lastly po, parang Ano ba sabihin? So I guess I should end there by saying na maybe through advocacy, we will be able to convince more people that this is really not necessary.
Okay. So there is the clarification on the question of the health declaration form. The context of the health declaration form question is since the DOH has not adopted any guidance on the use of diagnostic testing upon resumption of work for employees, a symptom check or health declaration form was prescribed instead of employing diagnostic procedures for clearance. So, what can employers ask in screening employees for back to work?
So typically, ma'am, basically it will be what you ask from someone who may possibly be a close contact, di ba? So are there symptoms, for example? Did they have any travel history to a place where they will have higher risk, for example? Or will they or do they have any interaction with people who likely will have contact with a COVID case? So it should actually be very simple declaration and encouraging everyone to say the right thing, no? So yun yung part ng health literacy and getting people to actually declare better. Kasi what we've known in some of the contact tracing we've done, people either don't want to tell the truth, they're not declaring their correct addresses, in the hospital, they don't even want to say what their case is, di ba? So, parang yun yung demand and supply side that we have to actually address po.
Okay. So there's another question. In the case of teleconsultation, could the clinician record their medical consultation with the patient? This is to safeguard against the legal cases that may possibly arise from a failure of care or possible libel. Dr. Tan?
Hello, Millie. You know that we discussed this question at length as well, and there were various opinions. Some of us in the informatics group said do not record the consultation because then you have to follow also the guidelines on how long do you have to keep it. So is it like the paper chart? So does it have to be kept, this video recording, for 15 years? There is a Data Privacy Act that tells us to safeguard data. So that means if you have this recording somewhere, you must make sure that there is no data breach or else you will be responsible for it. What is required in the Data Privacy Act is that if you're going to record something, it should have the consent of both parties. So the doctor has to consent and the patient has to consent. And if there's anyone else in the room, then the consent must be recorded or documented. So people will do various things. People might record. Then if you are going to record, please follow the Data Privacy Act. Get the consent, safeguard the data. If you don't want to record it, then that's why we provided the documentation template for the teleconsult. So in my private practice right now, as we also recommend in the document, give a copy of this documentation to the patient. So what I do right now, when I send an email to the patient that has the e-prescription and the lab request for the next visit, which is hopefully going to be face-to-face at my clinic in the PGH, I also send a summary of the teleconsultation. So I said, today we talked on so-and-so platform from 10 a.m. to 10:15. These are the things we discussed. Okay, I also put there that the informed consent has been signed, etc. So there's that, and we send it to the patient, and then there's an opportunity for them to say, well, no, you didn't say that. I understood it this way, etc. So, but these are the things that we're trying to do to help the patients also with the teleconsult. I don't know if I answered that adequately. We sometimes we need legal opinion, Millie, right?
Dr. Iris Tan, thank you for that. I totally agree with you. So what you're saying is that you actually document and you share that documentation of your conversation with the patient by sending it to the patient so the patient can maybe not argue and say, oh, I thought it was warm compress, but it was cold compress. Anyway, so there is there are two more questions. To increase immunity, should we allow the elderly with no comorbidities to exercise outdoors during the general GCQ or modified ECQ? Dr. Ho?
Ma'am, sorry. I think I was cut off.
Okay.
Sorry.
The question is whether the elderly who do not have any comorbidities be allowed to exercise outdoors during the GCQ or the modified ECQ. Is that to increase immunity? Is that encouraged?
So far in the guidelines, if it's outdoors but within still their house, it's fine, right? Because it's still their property. But if it's like going out, based on the rules that were set po along with the National Task Force, we're actually implementing it sila Secretary Galvez. No, it's still not possible. And also what we've shown in the guidelines, indoor physical activity is highly encouraged. But hopefully with GCQ coming hopefully soon for all of us here in Metro Manila, that should actually be possible. We're really encouraging it po.
Okay, thank you. There's a question for Dr. Iris Tan. The question is from Dr. Mantaring. If I am planning to charge patients for consultation, I can set up internet banking or PayPal, GCash as platforms for payment. Any guidelines with receiving payment and documenting these for BIR? May I just assign, use, or use one of my clinic receipts for this? Thank you.
Okay, so personally, what has happened to me is I'm not able to issue the receipts because all my receipts are locked up in my clinic. But I'm keeping a note of all the transactions, and I have instructed the secretary that when we reopen the clinic, then we will need to issue those receipts. And I've heard, for example, Dr. Eric Moral talk about this, and he said that he also makes the receipts, but he's not able to physically give them to the patient right now. But we should follow the BIR rules, and we should issue receipts. And I think Dr. Bev would agree with that.
Thank you. Okay. There's a question on for patients who do not have a printer and cannot print the consent form or do not know how to paste an e-signature on the consent form. How can consent be obtained or documented in such cases? May we ask the patient to also send a valid ID to ascertain their identity and legal age to give consent, and maybe even to counter check whether the signature for both the consent form and the ID are identical or similar. Dr. Tan?
That is a very interesting question. And I've had to grapple with some of those issues. So I said, if you look at our informed consent, it's about 3 pages long. Because I was also asked, what if the patient will just text that he agrees to the consultation. So, but apparently there's a legality to what should be texted. But in the bottom of that form, Millie, you know, diba, it has there several sentences. I think it says na nabasa ko ang informed consent na ito at ako ay, so there are like 4 or 5 sentences. We had that situation last week. So my secretary actually asked the patient to write that out on paper, the last 5 sentences that says he agrees. And then the patient signed it. And then I didn't even ask for it, but the patient also put a picture of his ID together with that paper. Maybe I have an advantage because I only see old patients of mine. I'm not seeing new patients right now. So I'm fairly confident about the identity of my patients. So I'm not so worried about that. I've also like sent the consent form that we have, Millie, as a photo so that maybe they can use it on the phone. Diba? You can like sort of doodle your signature. But you know, these are things that we're working on because I don't know, maybe the doodled signature is not the same as the actual signature. But we're trying to you know, get by. And the reason why we're publishing also our MIU guidance documents is maybe the lawyers, maybe the Philippine College of Physicians can help us out and write out those procedures. Because we're trying to come out with a separate document on the ethical legal issues as well. And maybe we'll have more answers as we get these questions because thank you for bringing that up. Now people have been wondering about that.
Thank you. Thank you, Dr. Tan. There's a question from Dr. Kate Gislani, some patients, old patients, are asking for medical certificates online. Can we issue one, considering we haven't seen them personally at this time? Dr. Ho? Dr. Ho, are you there? Dr. Ho, or Dr. Ho, can you please answer this question? Some old patients are asking for medical certificates online. Uh, can we issue one, considering we haven't seen them personally at this time? Uh, Maybe Dr. Iris Tan can answer the question. I'm not sure Dr. Ho is listening. Dr. Ho, yes, please. Yes, Dr. Ho. Dr. Ho, can you please answer the question? Dr. Ho, I'll repeat the question. The question posted by Dr. K. Gislani from Facebook. Some patients are asking for medical certificates online. Can we issue one, considering we haven't seen them personally at this time? Dr. Ho? Or maybe Dr. Tan can answer.
Um, During this past weeks, I've only been asked to issue a medical certificate once. And I had to clarify what the medical certificate was going to be used for. Apparently, the patient's employer wanted proof that he has diabetes because, as you know, diabetes is a high risk condition to get severe COVID infection. So I was very careful to put in my medical certificate that I saw this patient blank blank last February, and this is to confirm that I am seeing him for diabetes, and these are his medications. But I am unable to give like a anything else. Like I can't say the patient is unfit or fit or whatever. So it was merely a statement that yes, this is to confirm he is my patient and he has diabetes. So but I think that's the law is very strict, right, about issuing medical certificates. So you have to be careful on what how you word it and what it's used for.
Thank you, Dr. Tan. Uh, Dr. Ho, did you want to add something to that?
Okay na po, ma'am. Thank you.
Okay, so the question for Dr. Ho is, what could be a general guideline for conducting on-site annual checkup?
Ma'am, that hasn't been discussed yet in the DOH, and I don't think I'm at liberty to just say what pending any guidelines. No, but I'm noting all of these suggestions down, and perhaps we've tried to separate also our group now in the DOH. Some people are handling COVID matters, and some groups are really going back to the mainstream non-COVID pathway, and so this is something that has to be done really soon.
There is a question by Dr. Myla Rose Torillo. Is it possible to share your consent form or any other documents you use for teleconsultation? Is it feasible to have one consent? So this first question is addressed to Dr. Tan, but the second question is addressed to Dr. Ho. Is it possible to have one consent form that is issued or validated by DOH? Thank you. Dr. Tan, please.
Amoeba. Okay, so
Yes.
we released our informed consent, and it's part of our MIU guidance. But we said there that if it's going to be used by the hospital, that you need the data protection officer and you need the legal to actually sign off. There are parts of the consent form that probably needs to be customized. Like for example, for that part that in the cardio where they have to disrobe, etc. If you wanna be more specific and actually put it there, but in our consent form, we already have a statement, diba, Millie, that says you may be asked to do some physical exam maneuvers by yourself, etc. I don't know if the lawyers would agree that there will be only one consent form, but I would like to hear what Dr. Bevho has to say.
Dr. Ho? We can't hear you. Okay.
We don't have any prescribed forms. Okay na, ma'am. We don't have any prescribed forms now. So we're actually good with. I was just talking offline with Ma'am Iris whether this could actually be endorsed by the DOH, the guidelines that MIU has currently drafted, recognizing that it could actually really change. And we usually partner with the experts who issue out guidelines. So for example, in COVID, di ba, we just endorsed PISMID guidelines. So we'll see whether that's actually possible in the coming days. And so that will be the template informed consent that will be used. Thank you po.
Okay, thank you. So there's a question from Dr. Jose Ruel Tolentino. Is clicking I agree in a consent form or any internet document legally binding?
Millie, in our conversations with our MSHI group, I think someone sent a decision, was it from the National Privacy Commission, where we were discussing implied consent and expressed consent. So apparently, the patient has to do something active to signify that he has freely given his consent. So that is why I think we require a signature because that's more active. I'm not a lawyer, so I don't know whether clicking is considered already an action. So that should be fine. But really what we have in our guidance now is we require a signature.
Okay, thank you. Or maybe a thumb mark. Will that be acceptable as well? A thumbprint, a fingerprint?
So to the PCP, maybe the next forum, you should invite a lawyer to answer all these questions.
Okay. Dr. Ho, did you want to add something to that? Is the internet document legally binding if you click consent or if you click I agree?
I'm not a lawyer. I also don't know how this works. So I'll just I'm listing all of these down for our lawyers to look at po. Thank you.
Okay. Maybe I'll ask a question. What are your thoughts about the roving robot with the iPad being used being used in UST hospital to be used also maybe in the outpatient department for patients who say, I'd rather go to your clinic, but you would rather maybe limit the number of patients that you really see face to face. So can these be also utilized to minimize the face-to-face contact and yet they're able to access telemedicine if they do not have a platform or means of setting up telemedicine at home?
So I haven't seen that, but even before the pandemic started, there's actually an article talking about these robots that had the iPads and things. And there was one article where I think the doctor had to disclose bad news to the patient, and it was done through that interface, and the patient didn't take it very well. So that's why we have a patient guidance document, because we really need to ask the patients if how do they feel about the teleconsultation? Is this okay? Many of my patients have verbalized that they do want to see me in the clinic, but they also want to make sure that when they do, they will be safe. So we really need to ask those patient satisfaction surveys. We need to ask them, how can we help them? Is this something that we'll need to do again via teleconsultation? Are you willing? So that's why it's part of the informed consent, I guess. So some of them will only have audio calls, for example, and you miss cues. Like, umiiyak na pala siya, pero hindi mo narinig masyado na umiyak na pala siya. Yung mga ganun. So there are cues that we miss when we have an intervening technology. So we realized, for example, when we were listing our competencies, even if it's just a phone call, there are certain skills that we need to learn. The tone of voice, for example, kasi you miss the cues. You're not seeing the patient, so you miss the visual cue, right? I don't have a straight answer to that. We need to discover how to do this properly.
Okay, thank you. I think the human contact, the face-to-face consultation is still the best way of seeing our patients so that they can feel, they can know that we are truly concerned about them and that we aim to help them with the best possible care that we can provide. Do you
So it's
have?
a complementary approach, I think, rather than to replace.
Okay, I agree. So maybe Dr. Ho, yes, please. Did you want to say?
I just wanted to follow through with what you said and Ma'am Iris said. Seeing that yung face-to-face consult won't really be completely replaced, di ba? But we might be able to put in place yung certain practices. For example, sa atin kasi sa Philippines, hindi masyadong uso yung you come in at this time for your consult, di ba? Parang usually people just really wait for their doctors when they finish, etc. But if we say we wanted to limit people who come into the clinic, then we might need to really put in a good scheduling system, no? So in the public sector, this hasn't really panned out well. Yung mga SMS-based o 10:15, itong buntis yung pupunta sa center so that they don't line up. It hasn't panned out successfully in the past. But maybe now, because people don't want to converge in a small place like a rural health unit or lying-in center, maybe it's time for it to happen as well. And then we've also heard about several LGUs giving cell phones to their BHWs, for example, or load, so that kahit walang face-to-face, sometimes the people just actually need reassurance, di ba? So not always video yung kailangan, but people asking, kung ganito ba, do I need to go somewhere else already? So it's maybe not telemedicine per se, but a form of teleconsultation. So we also, sometimes kasi people are suddenly afraid of the word na parang sobrang technology heavy nung telemedicine, di ba? But it can also be done very simply po. Yun. Thank you.
Thank you. So I'd like to ask our two panelists, two speakers, for their last parting words. We still have 3 more minutes. Dr. Tan.
I'd like to thank the Philippine College of Physicians and the Department of Health for the opportunity to present at this webinar. I had my calls to action earlier. Please help us with that. The UP Medical Informatics Unit is willing to partner with people who want to bring telemedicine forward. Please do check out our guidance documents, and they are at bit.ly/UPMIU Telemed 2020. Thank you and keep safe.
Thank you. Dr. Ho.
Hi, ma'am. So from our end po in the DOH, we thank the PCP for this partnership, and we thank everyone for their time to attend this webinar. One of the reasons why we're doing this is also so that we will be able to get more timely feedback from you, one of our primary stakeholders. As we know, everything is fast evolving, and if we want reforms to happen within this short window of time, kailangan mabilis rin tayo, di ba? But we also acknowledge that we in the DOH, we might not have, and we really don't have all the capabilities, no? So parang we're also sort of really relying on our experts in this medical community to help us fast track certain things. Yun. So we hope that we keep the communication lines open para mas mabilis po yung progress ng health sector din natin. Yun. Thank you very much po.
Thank you. Before I end, I would like to read out the comment of Dr. Mark Homer Guillermo Chanco. He is thankful for this webinar, and he's saying that it is for patients to have medical services where it is not available. Now the telemed is a tool that is powerful and definitely will be helpful for our patients. It is important also to have us as physicians to be united with regards to this. God bless you all and keep safe. We'll pray for your safety and good health. So I'd like to thank our viewers, our participants for watching, for listening, and for asking questions. I'd like to thank also our two speakers, Dr. Iris Tan and Dr. Beverly Ho, for their very informative lecture. I'd like to thank the Philippine College of Physicians and the Department of Health for making this webinar possible. Thank you so much. Have a great day. Keep safe, and God bless us all.